The aims of the Commander HF trial with rivaroxaban were to evaluate the effects of this newer anticoagulant, rivaroxaban, a factor Xa inhibitor, on a composite of death, myocardial infarction, and stroke in patients with heart failure, recently hospitalized within 21 days, who had a left ventricular ejection fraction of 40% or less, also had coronary artery disease, but importantly, no atrial fibrillation. So these patients were in sinus rhythm, and compared rivaroxaban to placebo. The second aim, obviously, was to evaluate the safety of anticoagulation therapy with rivaroxaban in this population with heart failure. So we know that rivaroxaban is an effective anticoagulant agent, a newer oral anticoagulant in different settings for prevention or treatment of thromboembolic disease, and also obviously in patients with established atrial fibrillation, where clearly it will reduce the appearance of strokes. Now, the rationale for this trial was to try to see if by anticoagulating these patients with heart failure without a history of atrial fibrillation, that heart cardiovascular event rates would be decreased in this patient with heart failure. Now, in terms of the rationale, going back to prior data, while an older anticoagulant, warfarin, did not show benefits or provide convincing evidence for anticoagulation in patients with heart failure, there are data that are soon to be published with rivaroxaban in a subgroup analysis of a trial called Atlas 2 ACS that appeared to show benefits of adding rivaroxaban in patients that had a recent acute coronary syndrome and had a prior history of HF. So to be eligible for the Commander HF trial, you needed to have evidence of chronic heart failure. You needed to have evidence of left ventricular systolic dysfunction with an ejection fraction of 40% or less. Importantly, you needed to have been hospitalized for heart failure within the last 21 days. And you also needed to have evidence of chronic coronary artery disease. So what separates this particular trial, Commander HF, from other trials? Well, A, it's the agent. Most trials that have evaluated anticoagulation for prevention of cardiovascular events in patients with heart failure were conducted with warfarin. Warfarin is an older agent, probably a suboptimal agent in several settings, including AFib. And so obviously it was now time to test a newer agent like rivaroxaban in this patient population with heart failure. So the lessons from the Commander HF trial, in my opinion, are A, the vast majority of events that occur in patients with heart failure are rehospitalization for heart failure and death. The second lesson, given that the results are neutral in Commander HF, it appears that these events, rehospitalization for heart failure and deaths, are not related to thrombin generation and hence are not being prevented by anticoagulation with rivaroxaban. Thirdly, there was, interestingly, a reduction of strokes with rivaroxaban versus placebo in Commander HF. In the context of a primary endpoint that was neutral, perhaps one could say, let's take this with a grain of salt, but when you look at the totality of evidence, prior studies with warfarin in heart failure, studies with rivaroxaban like COMPASS and Atlas 2 ACS have shown that you can reduce strokes with anticoagulation. So Commander HF clearly shows us again that you can reduce the number of strokes in these patients with heart failure. And then the last point is there's a price to pay. The price to pay being there was an increase in major bleeding risk in Commander HF with rivaroxaban 2.5 BID versus placebo. Globally, the take-home message, in my opinion, is there is not a firm indication for oral anticoagulation in patients with heart failure in the absence of atrial fibrillation.